What's going on, everybody? We are doing a solo EMS-themed podcast today, which I'm excited about. We'll get into here in a minute. Sorry I haven't been putting out stuff as consistently. I didn't put out an episode last week just due to being super busy. On top of my normal part-time jobs, I've also been working as a movie set medic for a movie that's been filming up in this area recently. And that's been taking all my regular days off to devote towards that, which has been really fun. It's been a very busy schedule, but worth it. I've gotten some really cool experience. I've gotten to see a lot of things I wouldn't have seen working on an ambulance. And for the job, it's actually pretty easy. Most of the time, I'm just handing out ibuprofen and electrolytes and making sure people are drinking water. So it's been fun. I've enjoyed it quite a bit, but I've been busy. So podcasts have had to take a bit of a back seat, so I apologize for that. But we're back with a good one today. I'm excited to talk about this topic. I put out a message on Facebook, which I will read if I pull it up here. I said, EMS friends, I'm doing a podcast soon and want to know, what are your EMS hot takes? Comment or DM them. And boy, oh boy, did you guys deliver. I had quite a few really good responses with some really good hot takes. So I'm excited to dive into them and talk about them a little bit. I've also got a few of my own I'll throw in there and discuss. But I'm interested to see what you guys think of this and some of these opinions on here. Some of them I agree with. Some of them I don't. Some of them I'm kind of on the fence about. But there's some really good opinions on here, some really good discussion points. So let's get into it. Also, I should say before I start, sorry for the background being my messy apartment. I tried to position the camera in a way that wasn't going to be, I guess, picking up my dirty apartment or my messy apartment. I just haven't had time to do a deep clean in a little while and pick up stuff. So there's that. Sorry, not sorry, I don't know. You can listen to this instead of watching it if you want, but all right, I'm going to open up with my first hot take, which is placing a Lucas or mechanical CPR device should not be an initial intervention in cardiac arrest. I said it. This is actually a topic of discussion that's been going around lately with the new AHA protocols that have come out recently, and that they were... with not having the specific stats in front of me, they basically were saying there's no statistical difference in quality of CPR outcomes with the use of mechanical CPR versus manual CPR. So it's been quite a discussion of topic of discussion lately, and I've had this opinion for a while that I don't think a Lucas should be an initial treatment in CPR. And I say that because there's been numerous cardiac arrest scenes that I've arrived on scene of, and maybe there was another EMS crew there, or they had access to a Lucas, and it was placed before other interventions were completed. More recently, I went to a cardiac arrest scene where the Lucas was on, but nobody was bagging the patient, which is wrong. There was plenty of hands to do manual CPR. There's plenty of hands for someone to have been bagging and oxygenating the patient, but the Lucas was already on, and that was prioritized as an intervention. And while I do think the Lucas has its place, I don't think it should delay the initiation of other treatments like bagging and ventilating your patient, putting the AED pads on, and doing manual hands-on CPR. And I've just seen that too many times, so I'm pretty opinionated about that. I think when the Lucas came out, or if you're using like the Thumper or the other one, I can't remember what it is. This is the whole product. If you're using any mechanical CPR device, I think when it was first put out, it was pushed as like the device to use in CPR. Like if you're going to make a difference in a patient, this is what's going to do it. And that's just not wrong. I don't think statistics prove that, as we see with the recent AHA updates. I also I think I've seen it well, I have seen it delay other interventions way too many times, and just don't put it on initially. I think it does have its place. Like if you're a small crew, you're limited manpower, and you can do these other interventions first while doing manual CPR, and then you can free up some hands by putting this on at one point. Okay. Um, if you have people that are doing manual compressions, but they're all getting tired and the quality of their compressions is dwindling, then yeah, go to a mechanical CPR device. But certainly don't delay ventilating patients. Don't delay compressions, manual compressions, and don't delay electricity, especially the compressions and electricity. If you're going to save a patient in cardiac arrest, those are the two most important things you're going to do and that need to get done. So if you can start manual compressions and put AED pads on someone and do a rhythm check or shock if needed, do that. But certainly don't jump to a Lucas device as being your first intervention. It delays other treatments, and it will drastically lower your patient's chance of survival in those situations. So my typical practice has been I won't even grab the Lucas if I'm going into a cardiac arrest. I'll leave it in the ambulance, or if I have enough hands for people to grab it, we'll bring it in with us. But it'll be left off to the side, and we won't do it until I am manually doing compressions. I have AED pads on, and probably after my first round or two of medications and rhythm checks, and I'm ventilating the patient. That's been my practice. I don't jump to the Lucas quickly, and I don't think you should either. Um, but yeah, what are your thoughts on this? What have you experienced in this area? Comment them below or hit me up and let me know what you think. That's that's my first hot take. Yeah, I think it's pretty important that we have the order of events in cardiac arrest down, and I don't think Lucas should be a first one. So, all right, we're gonna get into. I'll have another hot take at the end. We'll finish up the episode with, but we're gonna dive into some of the hot takes you guys have shared with me. Um, Quite a few people commented on them. I'm probably only going to share your first name, because I didn't really ask anybody if they wanted their name shared. So I'll just share your first name. You know who you are. And let's get into them. So, Brian, how you doing, Brian? I haven't seen you in a long time. Hope you're doing well. Some of these through some of these or some of the comments that the people have left are some of them are phrased as hot takes. Some of them are just kind of a general topic that tend to be an area of debate in EMS. But we'll get into them nonetheless. So, Brian, your first comment was, how much equipment do we really need in a rig? Which is interesting. This has come up lately too. In New York State, we have what's called the Part 800 list, which lists the required equipment that we have to have on our ambulance. There's quite a few things on that list that are outdated or that we just don't use anymore or consistently. And there's quite a few things that are newer technology, that are newer meds and things that should be on that list that we should be carrying. So there's I think there's a lot of things that are outdated or things that we need to add to the list. I found this out recently. Vermont, who's our neighboring state up here, if you're an ALS ambulance in Vermont, you are required to have a pump on your ambulance, which is really interesting. And I think is a good move. I think we should have pumps on our ambulance. I think it helps us be really specific with our medications. We're not over or underdosing. It helps us keep track of our medication administration a little bit better and be very not specific, but very accurate with the amount of medication we're actually delivering. In the sense of, like, if we're hanging a drip on a patient and we have to deliver, we're doing a norepi drip, we're doing 2 micrograms a minute. If we're throwing that into a 1,000 bag or 250 bag and we're just trying to calculate a drip through a 60 drop set or a Vilaflow or a Dilaflow, sorry, it's hard to be accurate with that. And it's also hard to consistently keep track of that and make sure it's flowing. Depending on where we have the IV in the patient, it might get kinked if they move their arm a certain way, or the tubing might get caught. And that's something that a pump will help us keep track of. That'll alarm if the medication isn't able to flow, we can get very specific in our medication administration and just be very accurate as providers, which we need to do. I had a patient that I administered norepi recently. He was in septic shock. His pressure was very low. Wasn't perfusing well. He was hypoxic, so we were very aggressive about oxygenation and airway management. We were also very aggressive about fluid administration and putting on pressors to help support his blood pressure. And at this agency, I didn't have access to an IV pump, so I had to kind of eyeball it in a sense. And while it got the job done, we were able to help kind of resuscitate that patient and bring his blood pressure up and actually help his mental state return to normal, which was really cool. I couldn't be accurate in what I was administering, which is a problem because when I bring him to the hospital, if I could tell them that I did 6 micrograms a minute of norepi, if I could tell them that and I know that that works, then that's something that they can use to help that patient and administer the same medication on their pumps. But if I just hung a drip and I kind of guesstimated how much I was administering based off the amount of drips that was going, or I was able to kind of dial it in with the dial of flow, I just can't be as accurate. So the continuity of care is an issue with that. And it's our job as professional or as EMS professionals to be as accurate as possible with these medications. So I guess that's another hot take. We should have pumps on our ambulances. We really should. But yeah, Brian, that is a good equipment or a good question. Is how much equipment do we really need in a rig? There's another topic here soon that kind of covers that. But what are your guys' thoughts? Do you think there's stuff we should carry on an ambulance? Is there stuff we should get rid of? That's a requirement. Comment below. Let me know what you think. Abby, you delivered. I got a message from you that, first of all, how you doing? I haven't seen you in a while either. I put this question out, and you sent me a DM with an entire list with some hot takes. So I'm excited to get into these. Some of them made me laugh pretty hard. And there's some really good ones in here. So your first one is that seniority does not equal competence. Whew. That is a really good one. And it's very, very true. I think that people forget that being a clinician or practicing medicine is practicing medicine, and that we need to consistently be doing things to practice our skills, to review knowledge, to learn new things, to update our protocol or update ourselves on our protocols and best medical practices, and people just don't do that. And you could have someone that's been on the job for 30 years, but they are 25 years behind on their medical practices, or they're doing things that we just should not be doing as clinicians anymore. So I absolutely agree with that. Seniority does not equal competence. Competence comes from continuously practicing, continually bettering yourself, always asking questions, and just trying to improve yourself as a provider. So absolutely agree with that. That was a really good one. Your second hot take was burnout isn't seeing trauma. It's from bad management and low pay. Yeah, I could agree with that. There's a certain aspect of burnout that has come from the call types and the things that we see in EMS, but bad management and low pay definitely plays a part in that. I think there's a lot of times where it's easy to be running calls all night. You're seeing some crazy stuff, and if your management isn't there or your pay isn't there, you're starting to question why you're in EMS in the first place. And the job working at Starbucks for about the same amount of money is looking very attractive in those moments. I'm not going to lie. I've been there, I'm sure, as well as everybody else. But bad management and low pay certainly plays into that. That's why I'm a pretty big advocate in going to agencies that will compensate you well, that offer really good training, that have a really good crew and good supervision, and that's going to support you as a provider and clinician. That helps the rest of your job be so much easier. And it is important. I've left jobs because those needs weren't met. And at first, I think there was a level of loyalty that I was afraid of breaking because I liked working at the agencies as far as like the area and some of the people that were there. But if they weren't meeting those needs as far as compensation and structure, It's just not worth it. Go find a place that will help you with that. A very good one. Your next opinion, we got quite a few that I work with Abby, but Abby's next hot take was the frequent flyer often understands the system better than new providers. Which is kind of an interesting one. I haven't really thought about that too much, but I think there is some truth in that. As in, people that use the EMS system a lot do tend to know the in and outs of it. They know how to play the system. They know how to get it to meet their needs, even though it might not be the most appropriate use for EMS. That is pretty interesting. Not a bad take. Abby's next one, scene safety is ignored until it suddenly isn't. Yep, that's very true. There's been numerous times where you'll go into a scene. Oh man, my battery just shut down. Stand by. Sorry, guys. You can continue listening. I'll turn my camera back on here in a minute. It needs to cool down, I think. But there's been numerous times where you'll go into a scene and it may seem safe at first, but you don't realize that there's weapons around, there's drugs around, or something that could be harmful that we just don't pay attention to until we need to, or it's put in our face. So that is definitely true. Scene safety is emphasized almost to a joking level. If you've done New York State EMT classes, it might be a national thing too, but when we used to do our skills, like our PSE skills for class, we always used to have to say PSI or BSI scene safety and verbalize that, and everybody would hold up their hands and say BSI scene safety. And that was an attempt to help it register in our mind that we need to be checking for those things, but I think it kind of made people think of it as a joke and kind of an afterthought for actual scenes. So a good habit to get into is, if you're going into a house, before you make contact with the patient, look around. Try to notice, like, just pick out 5 things to notice. Like, oh, there's a phone there, there's a bed there, there's a couch there, whatever. Just look around the room. Make it a point to notice things in the room and see what you'll start to notice from a scene safety perspective. If there is risks or things you need to take care of, or you need patrol there for some reason, maybe you'll start to notice them a little bit better. But yeah, that was a good one. Hold on, let me try to turn on this camera again. And we're back. Okay. All right. Next hot take. Most calls don't need ALS, but ALS is expected anyways. This was an interesting one, and this is one that I don't agree with. I think this may be dependent on where you're providing EMS or where you're working, but saying that most calls don't need ALS, I guess it's a little mixed for me. I think there's a lot of calls that are BLS, that BLS care is appropriate for, in the sense that people do abuse EMS. They call for things they shouldn't call us for. That is true. But I also think that there's way too many calls that are sent in BLS that should be ALS level calls. And I think of things like cardiac patients. How many times have we seen a cardiac patient or a patient that's lightheaded, dizzy? Their vitals are stable. They don't have a cardiac history. They're not complaining of chest pain, but they're dizzy. As medics, do we do much further examination into that area? And we should. We should be absolutely doing a cardiac workup. We should be doing 12 leads and seeing if it is anything cardiac related. And I think that gets skipped a lot. And I've seen that get skipped a lot. So while I do think that BLS care is appropriate for a lot of calls, obviously, I do think that ALS can get kind of put on the back burner, and people can be lazy with their medic skills after a while. So I'm kind of on the fence about that. I wouldn't say that most calls don't need ALS, and I don't think that all calls need ALS, but I think a lot more calls should receive ALS care than they are currently. Your next one is kind of along the same vein. ALS interventions don't significantly change outcomes in the field compared to high-quality BLS care. I have 2 trains of thought with this. One, BLS always before ALS. BLS interventions, as far as airway, breathing, circulation, should always be prioritized in patients, no matter what the call type is. And I think this does get lost in ALS providers. Sometimes it is easy for us as medics to think about what ALS interventions need done when we might be neglecting more aggressive airway management or oxygenation or circulation support. So I do see that aspect of things. I will disagree in the sense that ALS interventions uh, do significantly change outcomes in the in the sense of discharge from hospital. So and BLS interventions as well. So one thing that we can really shine on in EMS and we could be rock stars about is early recognition and notification of certain conditions. So things like sepsis patients. Sepsis patients have a high mortality rate, and I think in New York State, at least, there's been kind of a big push for this in recent years for EMS recognition and hospital notification of sepsis patients. And we've got very clear criteria that we can use to notify or that we can filter patients through to see if they meet the criteria. And if they do, then we'll notify the hospital that this is a sepsis alert, with the goal that they are going to be ready for us. They're going to be very aggressive about treatment and initiation of certain medications. So I think that is an area that we can be certainly better at. That's an all over level. That's like BLS and ALS thing. We can be really good at noticing these things. From an ALS perspective, I think EMS could be a lot better at recognizing cardiac issues and being advocates for our patients when it comes to cardiac related complaints. And that's where I think we could really shine as far as the as far as changing outcomes. I like to give this example. My father recently had a heart attack. He had a end STEMI, and he had 95% occlusion of his LAD, and I think 98% in his left main artery of his heart. He was transported to the hospital by EMS, and they did not take him to a hospital that had cardiac capabilities. So there was no cath lab, there was no cardiologist, there was nothing here. It was pretty minimal. I think kind of like a critical access hospital. And I think they did a 12 lead on scene, but I don't think they saw the classic STEMI that they should have seen. But if they did look out for things like T-wave inversions, really that they would have known that there was something cardiac going on and that he really should have been brought to a cardiac center. Thankfully, he's good. They were able to recognize that he was having an end STEMI and go through the paces for that. But if we as medics are able to identify abnormalities in 12 leads better, instead of just recognizing STEMIs or VFib or VTAC or whatever, if we can notice those small changes or those pre-indicators for STEMIs or pre-indicators for end STEMIs or whatever, I think we can make a huge, huge difference in our patients as far as where we're transporting them, notifying a hospital of these things, talking to a doctor and sharing your concerns with them, and getting them care quicker. It makes a difference. It really does. Timely management in these situations saves tissue. It helps prevent further damage of cardiac tissue, all kinds of things, and not even just cardiac events, but also strokes, things like sepsis, all of that. I think we could really be better about changing outcomes if we are more aggressive about those things. So that is a really good hot take, Abby. ALS, again, your statement was ALS interventions don't significantly change outcomes in the field compared to high-quality BLS care. I always agree BLS before ALS. We should be managing airway breathing management. But I think we could go a lot further in EMS, and people should be doing more in advocating for their patients, which will lead to changes at discharge from hospital. So one kind of statistic I saw via Google, I'll read the statement. EMS care significantly impacts mortality with faster response times, ideally under 13 minutes, and timely interventions, drastically improving survival, particularly in cardiac arrest where delays cause a 9.3 to 10.7% decrease. I didn't mean to read that statistic. There's, let me see, stand by. This is the one I meant to read. I meant to read that one for the Lucas one, but EMS care significantly impacts sepsis mortality, for instance, facilitating early recognition and treatment, which reduces time to antibiotics and intravenous fluids. Anybody can recognize sepsis. We talked about sepsis a little bit on the episode with Jake Potter, which you should go listen to. I think it was episode 3 or 4, maybe. We talked about sepsis care in the pre-hospital setting and aggressive fluid administration and pressure support and all that kind of stuff. But this is an area where we could really make a difference and help our patients. So to put this in perspective, if I have a patient that is has a known source of infection, they are tachycardic and they're febrile, that is enough for me to say this person is septic or meets the qualifications for sepsis, and I need to bring them to a facility, probably a facility that has ICU care, because if they are sepsis, they might be going there for a while to receive further support. And I need to be aggressive about treating them and doing things like fluid administration to help support their body in fighting that infection, pressure support if needed, that kind of thing. Anybody can recognize it. ALS can really make a difference in early treatment and just making a difference in them. So any sepsis patient I have, any suspected cardiac patient I have, any stroke patient I have, all of them get 2 large bore IVs if I'm able to do it and if I have the time to do it. All of them get really good detailed reports to the hospital via the app that we use to notify them. Most of them are going to get medical control consultation. So I will talk with the doctor about their care on the way to the hospital, and I will make sure there's nothing I'm missing and just put it in the doctor's mind that this is what's coming in. They're really sick. We're going to need a room, and you're going to need to see them pretty quickly. That in and of itself is a really good step to take for EMS in helping these patients. If I can have 2 large bore IVs in place, that saves the nurses time from having to do IVs. I can do it on the way, and when I get to the hospital, they can start their blood draws. They can start doing assessments a lot quicker if I have those things in place. If I talk to a doctor, that just puts in their mind that, hey, this person's probably septic. I need to be hopefully aggressive about treating them. And then I need to see them pretty quickly. And then good notification to the hospital that you're coming in, whether it be via radio report, phone call, or an app. That just lets the charge nurse know, hey, this person's coming in, they're really sick. I probably need to have a room ready for them. And those are very simple things that EMS people can do, but they are very effective, and I don't think they should be downplayed. Anyway, that's a rant. I'm talking a lot more about these things than I than I thought I would. Yeah, that's a good one. I think ALS interventions do change outcomes in the field, and we should be good clinicians when it comes to that thing. So okay, I'll move on from that. Abby, that was a good one. You got a few more to go through, Abby. Your next one, pain management is still undertreated because providers are overly cautious or judgmental. Say it louder for the people in the back. This is quite the topic of discussion. I get in disagreements with people about this fairly frequently. People who are very conservative in their pain management for patients, and man, there's so many trains of thought. So I think one of the biggest hesitancies and the thing we hear discussed the most in use of narcotics in pain management is, are we as EMS, when EMS gives a patient narcotics, are we putting them on a path of narcotic use? Or are we encouraging a current addiction with narcotics? My general take on this is if a patient is in pain and I can do something to make them more comfortable, I'm going to do it. That's not to say not every patient that has pain is going to get management. If someone has a cut on their finger and it hurts, but it's manageable, I'm not going to give them narcotics. If someone has severe abdominal pain and they're doubled over, I'm going to give them narcotics, or I'm going to at least offer to give them some. Um, I'm not lazy in that. I will admit that I push for people to get pain management. I try to educate my patients in saying that this will help them be more comfortable. It'll help them relax a little bit more. Could help improve their condition, whatever it is. And I'm just pretty solid on this as far as wanting to give pain management, and I'm very willing to do it. We also have other options now, so even if someone is hesitant about narcotics for one reason or the other, we have options like ketorolac or IV Tylenol, which is a phenomenal treater of pain. It does a really good job, and it works in almost every situation that we could do pain management in. Also, this is something that doesn't get done enough, but we can do what's the word? We could do multiple routes of pain management, and I'll think of the word here in a minute. But multimodal, that's the word. We can have multimodal ways of or means of treating pain, and they tend to work pretty well. And the hospital does this all the time. I feel like we don't. We're pretty conservative in EMS with our pain management. We shouldn't be. We really should be aggressive about treating these things. So that is a good hot take. I think someone else has a comment about that here soon, but we should be using pain management a lot more than we are, and offering that to our patients. From a addiction perspective, me giving someone pain management one time, I don't think is going to cause them to become addicted to it, especially with the means and the routes that we do it. If you're not in the medical field and you hear and you're offered narcotics as a means of pain management, just know that it is very safe and controlled. It's not like street level narcotics. It is manufactured in a medical facility that is very, very controlled and regulated. It's very safe to use. And if you have questions, just ask. But EMS providers, we should be good about educating our patients on this stuff and telling our patients these things and providing them with the options if they want pain meds or not. But good take, very good take. Next one, Abby, is EMS is not a calling, it's a job, and people treating it like a calling is why people tolerate poor pay and conditions. Okay, that kind of ties into your earlier statement about burnout being from bad management and low pay. I think EMS could be a calling for people, but at the same time, it is a job. It is work that needs to get done. We should be receiving compensation for this in one way or another, and people treating it like a calling to tolerate poor pain conditions. I can see that happening. In fact, I have seen that happen. That is true. Confidence is often mistaken for competence in paramedics. Well, goddamn, that's a that is a hot take. That is for sure a hot take and very true. In with your next point, you also say some providers hide weak knowledge behind aggressive personalities. That is very true. Confidence does not always equate to competence for your job. That is very true. In fact, I would say having an aggressive personality or having false confidence is dangerous for your patients because kind of like the earlier we talked about earlier, you should be continuously learning and continuously improving yourself. So if you're a confident provider, that could be okay, but there's still areas you could always improve on. Again, this is a practice of medicine. We should be improving on ourselves constantly. So that is a good one. And then Abby's last one, the quote, eat your young, end quote, culture is still very real and widely tolerated. That's true. Yeah. I think we could do better in EMS about facilitating growth and training with our newer providers and having better systems in place for that. But thank you, Abby. That was a good one. Those were all good ones. Definitely some really good topics of discussion. And let me know what you guys think of those down below. Comment them, tag me in them, put your thoughts out there. I want to hear it. I'd love to get a discussion going. Let me know what you think. Luke, what's going on, Luke? I haven't seen you in 2-3 years, I think. I believe you're out in Ohio. You're a paramedic, firefighter out there. You've got one that I'm really excited to get to, but we'll get there here soon. Your first one was clinicians withholding narcotics narcotic analgesics more often than they should. And again, we just discussed that. I totally agree with that. We should be more aggressive and willing to use narcotics because they work phenomenally. They turns out they treat pain really well. Um, this is an example of things I've seen. I've been on a call with a particular medic where I was not a fan. I no longer work with this person. Um, Someone had really severe abdominal pain, and we got this person loaded up into the ambulance. We're starting vitals and assessments. The medic at the time didn't even get in the back of the ambulance with me. They just went up to the front driver's seat and assumed that BLS care was appropriate. Meanwhile, this patient is doubled over in pain. They are quite literally screaming because their abdominal pain is that bad. I go up to that medic. I'm like, hey, I really think we could use pain management for this patient. We've got a long trip to the hospital. They need something to help them out. And the medic looked at me and said, well, nothing I have is really going to touch his pain. And that was it. Craziness, but this stuff happens. And it's a result of either poor education, laziness, inability to do your job well, or a combination of all of them. People like that exist, and providers like that exist. And one, if you're an EMT that works with somebody like that, you are not wrong to call that person out and educate them and be like, no, actually, your fentanyl would do really well in this situation to help this person be more comfortable, and we should be doing something for them. So feel free and confident to call out poor providers when you see it. Anyway, yeah, I'll get off that topic. Your next one was really interesting, Luke. You said AHA needs a competitor to balance out their pharmaceutical protocol, which is interesting. I'd not really thought about it from that perspective as far as having a competitor, but I think it makes a lot of sense. A lot of our guidelines for cardiac arrest or tachycardias or bradycardias, things along those lines, are based off of what the AHA recommends to us. And they're good protocols. For the most part, I will say that there are things that are outdated in those protocols that need replaced or changed or more research. And I think you have a point here, Luke. I think if there was another organization that was speaking into these things as heavily as the AHA is, then maybe we would be more advanced in our protocol. And the example I thought of, and what you're probably implying, is specifically with epinephrine in cardiac arrest. We've been cutting back on our epinephrine use in cardiac arrest significantly. Right now, our protocol says every 3 to 5 minutes, we will administer epinephrine up to 5 doses. That's the New York State specific one. That might be AHA recommendation as well. But we're not going to do more than 5 doses of cardiac arrest of epinephrine. And even that is probably quite a bit and a little overkill. So my practice has been I will follow the protocol, but I'm going to do every 5 minutes. I'm not going to do any sooner than that. I might not even give all 5 rounds of epi, depending on how the patient's presenting. But that is a very good point. I think that would be a good thing to look into. So that's good. This is your hot take that I was excited to talk about. You said backboards should be outlawed and replaced with a vacuum mattress. And then in parentheses, you say, from personal experience of breaking my back, I believe it did more harm than good. So Luke had, I believe you're okay with me talking about this. You did have a pretty bad accident a few years ago where you did break your back. And so I'm sure from experience, you experienced being on a backboard for a while. And I've heard quite a few people say that were in similar instances that were on a backboard for a while. And all of them said they think it did more harm than good. I completely agree with this. I hate I've never put a patient on a backboard other than maybe to slide them out of a car onto the stretcher or to do a standing takedown, things like that. But I do not keep patients on backboards long term. It is so uncomfortable for them. And if someone has a back or spinal injury and we're keeping them on a backboard, it is only going to exacerbate that problem even more. So New York State is looking into this actually. Along the same lines, they're looking into the use of cervical collars in spinal injuries and whether they are good or not, or whether we should be using them as often as we do. I know there's places like Florida who are replacing them with soft collars, or they're using them in only very, very, very specific situations. But for the most part, we're kind of stepping away from that, and I'm excited about that because it just makes our patients more comfortable. How many times have we had a fall patient who they say their neck is hurt? There's a possibility of some kind of spinal or back injury of some kind, or neck or head injury or whatever, and we have to put that patient in a collar all the way to the hospital. How many of those patients are fiddling around with it? They're moving their head anyway. The collar keeps popping up onto their chin, and we need to seat it back down and resize it or whatever. It's just uncomfortable. It is not a good option. It hurts for people. Some people just refuse it because they've either had them before or they just don't want to put up with it. And I don't disagree with them. I think I'd probably do the same thing. Um, yeah, that's a really good hot take. I think it's a scientifically accurate hot take. I'm excited to see some of the studies that are coming out about it, and see where we move in our protocols with that. But I do agree, backboards should be outlawed and replaced with a vacuum mattress. Um, although I've not played around with vacuum mattresses that much, um, to really be able to speak into them, but we could do it with backboards, and I'd be happy about it. Jake Potter, what's going on? You had the comment or the hot take that probably got the most comments under it, and immediate feedback on the post, which was interesting, and it's a good topic. And if you don't follow Jake, go follow him. He's an EMS educator and clinician out in North Carolina. A good friend of mine. We used to work EMS back in the day up here. We went through A school together. Yeah, we go way back. He's does a lot with Pass the Scope education, so go follow them. They put out a lot of really good podcasts and training stuff. But Jake's hot take: paramedics should have at least an associate's degree. Just got quite the comment section going under your post, and I know why you're saying this, and I think we've discussed this before briefly. There is a push, and I think it's a good push for paramedics to be trained better and more equipped for the things that we're running to in the field. And I have kind of a few different perspectives of this. One, I'll say that I don't know that an associate's degree is the exact answer to the problems that we're facing, but I'm not opposed to it either. The associate's degrees that are out there now currently that I've seen, at least in my area, will typically be like the paramedic program I went to. It was a year of schooling, and from that year I got my certificate to practice as a paramedic, and I passed my state test. I was online as a paramedic. I had everything I needed to do paramedic work. They offered an associate's degree off of that, and if I wanted to, I could have stayed for another year in school and done gen eds, more advanced, I think, anatomy and physiology, and other classes like that, which aren't necessarily a bad thing. It's okay to learn those things, but I don't think that's specifically the classes we should be doing to be better paramedics. It would help, but I think we could do things more like vent and pump training, SCT, transport training, things along those lines that are more applicable to our job. So yeah, I think we should be trained more and better compared to other medical jobs that are similar in practice and scope. Probably kind of paramedics and nursing is kind of similar in some aspects. Nurses are expected to have a degree. They have to go to schooling. They have to have associates, bachelor's or master's or whatever in nursing, and then they have to pass state tests and qualification tests as well. And that's just the standard. Yet paramedics are, we just have to take a course, So I do get it in the sense of I wish there was higher standards and trainings. I don't know that associate's degree is the exact answer. I would love to see kind of a revamp in some of the EMS education and requirements for training that are part of some of the paramedic degrees out here. But yeah, that is a good topic. What would be, and Jake, I'll ask this about maybe the next time you're on the podcast, but what kind of training would you guys like to see in the paramedic program that's not currently offered or that maybe wasn't offered in yours. Um, like if it wasn't a degree like a degree program, what could they offer to make us better equipped to do our job? But very good one. There was a lot of good comments on that specific hot take. Trevor, we got Trevor going up. What's up, Trevor? Awesome paramedic. Worked with him. Had some shitty calls together. It's a good dude. Had some good comments on here. First one was wanting. It's kind of a phrase or a topic conversation, not a specific hot take, but wanting to be known as professional, but not acting, dressing, or practicing professionally. I'll also say it louder for the people in the back. That is absolutely a thing that happens. There is still quite a bit of whacker mentality in EMS, and I think we just need to move away from that. I think there's absolutely a place for volunteers in EMS, but in general, we need to be more professional. We need to act and dress and practice more professionally. I'm still running into that constantly. Hopefully not with myself. I like to think that I'm pretty professional and dressed appropriately for the job, except for the backwards hat. I do wear a backwards hat, so sometimes people might think that's unprofessional, but I think people could do a better job at that, and us as EMS could push for this harder. Your next one was, you just said lack of uniformity. Yeah, I can see that. Kind of goes along the same point. Your next hot take was poor leadership or not holding leaders accountable. That for sure happens. There's plenty of agencies that need better accountability. It just is a thing, and we need to do that. This was a good one. Your last hot take was that there's a general abuse of the 911 system, and a lot of times the public don't know what an actual emergency is. Very true. There's a lot of calls, not a ton, but there are certainly calls we get that are just, it's not necessary for an ambulance to have been called. Either people are faking a medical problem and looking for a ride somewhere, or it is something very minor that doesn't require EMS assistance. That certainly happens. We will never tell people no. We will never not care for people. But I wish people had a better understanding of how and where they can receive the appropriate medical care that they need. And on the flip side of that, there's a lot of times where we'll do transports out of urgent cares or doctor's offices with people that have severe medical issues, or they're like shitting the bed in front of you, and you're like, why didn't you just go to the hospital, or why haven't you called EMS 3 days ago when this all started, That's happened plenty of times, more often than not, where people should have called or gotten care a lot quicker than they did, and now they're really sick, and we have to work really hard to help resuscitate them. So there is definitely a general abuse and lack of knowledge. I would totally agree with that. Krager's your first hot take. What's up, buddy? I think I saw you last week or something like that. But how you doing? Good to see you. Good to see your name, I guess. Your first one was burnout and anxiety and anxiety disorders in EMS professionals. Definitely happens. I think we know that. We talked about burnout earlier. It is easy to happen in this field. Anxiety disorders, wow, it is so common. One of the first and best pieces of advice I got when I was stepping into EMS was from an experienced paramedic who said, if I can give you one piece of advice, it's that anxiety is real and we need to treat it, or we need to be mindful of it at least. And that's so true. Anxiety, our patients have anxiety, we have anxiety, everybody has anxiety. It is something we will always run into, and we can't escape. And that's okay. Anxiety has its place. It is good for certain things. As EMS professionals, we need to know how to manage our own, and we need to know how to help others in managing theirs. But yeah, certainly a good take. You also had, Krager's, you had pros and cons of a 24/72 shift, which the agency we work for has that schedule. There's definitely pros and cons of it. If you're used to working like 12-hour, 8, 10, 12-hour shifts and then going home every night, there's benefits to that. It is nice to sleep in your own bed. It is nice to have dinner at home, those kind of things. On the flip side, it's also nice to work one day and then have 3 days off, unless you're working a bunch of other part-time jobs like I am. There's definitely pros and cons, but it is interesting. What are your thoughts on that? I know there's a bunch of different shift schedules out there. What do you guys think of that? All right. Craig Nessler. What's up, buddy? Craig's been on the podcast before. He's an EMT. He's also a comic friend of mine. You said firefighters are the best medics. I'm going to let the comment section handle that one. What do you guys think? Comment below. You also said EMTs should get ketamine. Nope. Moving on. He's for sure joking, but it was funny. Made me laugh. Mike, what's going on, Mike? You said, I'll give the hot take of hot takes. Whew. He said, EMS is more important than the fire service and should receive the majority of funding. Mike's out here trying to start fights. You're trying to make people throw hands. You're trying to make this podcast get canceled, Mike. That's what's happening. Man, so people are moving around in their seats, including myself, because I'm excited to see the backlash from this. But EMS is more important than the fire service and should receive the majority of funding. I think EMS, law enforcement, and fire are all equally important. In New York State in particular, this is an issue because until more recently, I don't think EMS was recognized as a necessary service. So there was a lot of opportunities for funding for the fire service or law enforcement that wasn't available for EMS. I think that's changed more recently, or it's at least in the progress or the process of changing. Certainly a good hot take. Well, there's certainly aspects of that that's a good hot take. I would never say that EMS is more important than fire service. What first responders do in general is really important and necessary and life-saving things. I will say that EMS is involved in all these aspects in a lot of ways. So if law enforcement goes to a welfare check, for instance, or a MHU or mental health related call, and they have a patient that meets certain criteria, they're going to call EMS, and we will often be involved in those calls or tied in somehow. We'll be giving patient care, or we'll be helping law enforcement. Same with fire. If fire goes to a car accident and they have the task of extricating a patient, or they have the task of rescuing a patient from a fire, that's obviously very important and life-saving stuff. But then that patient's passed off to EMS. So I'll say I think EMS is involved a lot in the first responder realm. There's a lot of bleed over to either side into law enforcement or fire or other areas. And I wish there was more of an emphasis on that in certain areas. I won't say that it's more important than law enforcement or fire. I think everybody has their place equally, and we couldn't function without the other areas. Yeah, that's quite the hot take, Mike. You're trying to get me canceled, and I got a lot of firefighter friends, and I am a firefighter, so that's a good one. All right, one more comment, and then I'll get into my final hot take. But these kind of play together, so I kind of staged it this way specifically. Paul, you commented, "I'm not an EMS person." But this is a true story. When my partner was taken to the ER a couple weeks ago, the EMT and I sang deep cut musical theater duets the entire time, and he had a surprisingly robust baritone. Not exactly a hot take. I'm just grateful for the extra mile you all go to take care of people. Thanks for sharing that, Paul. That's really cool. Whoever's singing in the ambulance, I've done it before. I had I went to a car accident one time where there was quite a few kids involved, and I had a younger patient, probably one or two, that I was transporting to the hospital. Their parents were in another ambulance going to the hospital, and I was just trying to find some means to entertain this kid, which most of the time means like pulling up Paw Patrol on my phone and letting them watch that. This one time, I decided it would be a good idea to sing nursery rhymes to the kid. So I was singing The Wheels on the Bus Go Round and Round, and I forgot the other verses of it, and I mixed in another song, and I ended up singing The Monkey on the Bus Goes monkey, 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 monkey. It's dumb. I know it is. You're probably not laughing. The kid looked at me like I was an idiot, and I was, because I was singing a nursery rhyme song completely to him wrong. And that's the thing that happened. That's a song that I sang one time. Um, yeah. Anyway, this ties into my final hot take, which is that aside from immediate life-saving measures, treating people's or patients' anxiety with compassion and education is the best thing we could do for our patients. Um, this looks different for people. So some people that I know are um, who are the best clinicians that I've seen are just solid at talking to their patients, helping them calm down, educating them in what's going on and what to expect when we get to the hospital. And they are just really good about helping patients in that way. And I love that. I wish that happened more. Um, I get that it's hard to do in some aspects. Sometimes we're tired. It's the middle of the night. We're not fully awake. We're responding to a call, and we might not just have the capacity to be over the top, compassionate and stuff. But we should make an effort to do this. And I think this correlates to better outcomes for our patients in general. One, it helps them relax. Like I've had plenty of patients. I've had heart attack patients or STEMI patients where we were honest in saying you are having a heart attack, you are having a severe STEMI. I was pretty thorough in explaining these things and educating them on what was going on with their body and what to expect when we get to the hospital. And I try to do so in a way that's compassionate and helps them feel comfortable. I don't yell at my patients. I don't. I'm not over the top in trying to be funny with them. I'm just compassionate, and I think that makes a big difference in these patients and helps them just relax. Because I want my heart attack patients or my STEMI patients to be relaxed. I don't want them to be overworking their heart or freaking out and making them more tachycardia and causing the issue to be worse. I want them to try to be as relaxed as I can, and I think this is a huge thing that EMS could do, and it's probably one of the best things we could do to help with the outcomes of our patients. Plus, it helps people just be more comfortable with us, um, and share more. We can get a better history if people are more comfortable with us. Um, all kinds of stuff. So I think this is a really important thing. I wish people were more empathetic and compassionate in EMS. If you are and you do that regularly, good on you, and keep doing that. Certainly have really good EMS skills. Know your shit. Provide life-saving interdictions, interventions as appropriate, but certainly mingle in compassion and treat people's anxiety as best you can. That's it. That is hot takes galore. I think we've been going for well over an hour now. I've been yapping the whole time. I appreciate you guys listening. Yeah, this has been quite the experience. On that note, I'm going to end this by I want to dedicate this episode to a local firefighter and friend, Mickey Guy. It's pretty public now. She was involved in a just kind of a freak accident at work the other day. You can look up details of that, but she is a very kind and compassionate provider. She goes over the top for her patients. She helped train me, and she was my AEMT instructor as well as one of my EMT instructors. And she's not doing too hot right now following that accident. So in the link below, there's going to be a link, or you're going to find a few links. One to a GoFundMe page where they're trying to raise money to support her and her family through this time, and just meeting basic needs like hospital stays, getting food, things like that. Just go follow along and support if you can in that. But this episode is dedicated to you, Mickey. You're a hell of a person. I know you're super strong. You'll get through this. But yeah, to Mickey Guy. And just reach out and support them as you can. And if that means you can donate financially, that would mean a lot. So Anyway, thank you guys. Thanks for listening. Thanks for staying with me this whole episode. If you have any other hot takes or things we could discuss, comment them below. Follow on YouTube, Apple Podcasts, Spotify, the whole nine. Go follow me on Instagram and Facebook at What's Going On Podcasts, and follow my personal page at Caleb James White on Instagram, Facebook, TikTok, the whole nine. Thank you guys. Thanks for everybody that submitted. Appreciate you guys a lot. Yeah, I need some kind of cool sign-off thing, but anyway, what's going on? I'll see you later.